attendees are in listen-only mode.
Series, which is on patient safety. We will have the two presentations by the speakers, and then afterwards we'll open it up for questions, both here at WHO in Geneva and also anybody who wants to ask any questions via the webinar. So we're very privileged today to have as our main speaker Sir Liam Donaldson, who has a distinguished career and many occupations and appointments. I'll just give a few because the list is quite extensive. Sir Liam is the WHO Envoy for patient safety, and he's worked with the World Health Organization in several different capacities as chairman of the World Alliance for Patient Safety, and under his leadership the patient safety program grew from a small initiative within whose health systems activities into a global advocacy and scientific community. But he's also been involved with WHO. He was a chief medical officer for England, and during his time he represented often the United Kingdom on in international fora, including the governing bodies of the World Health Organization. Currently he is also chair of the Independent Monitoring Board for the Global Polio Eradication Initiative. He also has academic appointments in England. He's Chancellor of Newcastle University, and he's a chairman, he's a professor at the Imperial College Global Centre on Health Innovation. He's also the author of many landmark reports on many aspects of public health. So I'd like to invite Sir Liam to come and give his presentation. Thank you.
Thank you very much, and good afternoon to everybody in the room and to everybody watching on the web. As the chairman said, we're splitting the time. I'm going to give my overview of the history of the patient safety movement globally, and then Ed Kelley from the WHO patient safety team is going to respond and give some reflections of his own. So the key moment I'd like to take you back to was the beginning of the 21st century, the end of the 20th century, the beginning of the 21st century, when two seminal reports were produced. One in the United States by the Institute of Medicine called To Err is Human, and the other one, a group that I led in the United Kingdom, who produced a report called An Organization with a Memory. And the importance of those two reports was that for the first time they scoped the subject of patient safety. They put together, insofar as is possible, some data on the burden of the problem, and they talked about how improvements in risk and safety had been made in other industries but not in healthcare. And they talked about what might be needed to take patient safety as an issue forward within the healthcare system. Coming then to the WHO response, when I was the UK's representative on the WHO Executive Board, the Director General at the time was Dr. Brundtland. I asked the board whether I could give them a lunchtime presentation. And I gave them a PowerPoint presentation on patient safety, and then with other members of the board we put together a draft resolution on patient safety. As many of you know in the room, but maybe not listening on the web, that in order to get a resolution through the 193 member states of the World Health Assembly, which occurs every May, you first have to put the draft resolution through the executive board. And obviously, depending on the issue, there are a lot of international politics around different resolutions, but this one didn't have any politics. Everybody liked the idea, they were enthusiastic about it. In fact, I was inundated with other countries that wanted to become co-sponsors of the resolution, and then it went through the World Health Assembly the following May as resolution 5518. It went through on the 18th of May 2002. It was a broad resolution, but essentially for the first time in WHO history, the term patient safety was used for that aspect of quality of care which is to do with preventable harm and risk to patients. And it called, in general terms again, about promoting patient safety as a fundamental principle of all healthcare systems. So this was a very important moment because the two reports that I referred to a moment ago were very much advisory reports. They were expert reports advising mainly the governments in their two countries, the United States and the United Kingdom. But this was for the first time the WHO's member states, because all 193 signed up to it. It was them saying, we want to adopt this as a philosophy within our healthcare system. So globally, that was the first time things started to move in a planned way on patient safety, but it was also a very opportune thing because it was a global movement that started rather than a piecemeal movement which was then made global by bringing together enthusiastic countries. Everybody signed up to it, and there was no opposition and general enthusiasm. Of course, that doesn't necessarily mean that action flows from it, but it was done very, very quickly. It moved from a lunchtime seminar to a draft WHO Executive Board resolution within the same meeting to that same following May, an adopted resolution of the WHO. So it was a good, fast-moving process. And then the enactment of the resolution, there was no particular precedent for how to take it forward, but we suggested that we should create something called the World Alliance for Patient Safety, which was rooted in the WHO, but allowed a very broad partnership. And at the time my day job was United Kingdom's Chief Medical Advisor, England's Chief Medical Officer, and but I was asked to chair in the few hours that I had left in my life, I was asked to chair this World Alliance, and we sat down and we put together a program. The UK very kindly donated £25 million, and by that time the new Director General, Dr. J.W. Lee, had been elected, and he was also very enthusiastic about this subject area and very supportive, as Dr. Chan has been. So we've been lucky in we've had Director Generals who are willing to regard this as standing as quite important in their priority list. So what was the state when the World Alliance for Patient Safety started its first foot forward program? What did patient safety worldwide look like? Well, at the beginning of the 21st century, my insight into this at the time was that patient safety was something that academics and enthusiasts were pursuing around the world. It wasn't mainstream to medicine, nursing, any of the healthcare professions. It wasn't mainstream to health policymakers. It wasn't mainstream to those leading healthcare systems. It was a fringe activity, interest of enthusiasts and academics. So there was disinterest. The scale of the problem, the burden of disease, was not well recognized, and so there was ignorance. The incidents that did occur when a patient was killed due to the maladministration of a medicine, for example, they tended to be seen within healthcare institutions as isolated parochial events. Something could be learned locally, but really there wasn't any general message to come out of it. Comparing that, for instance, for when an air crash happens in that industry, the investigation isn't just for the airline concerned, it's also for the whole of the industry. That didn't happen in healthcare. So there was apathy, thinking, well, you know, we've looked at our problem and we don't need to, don't need to look in on what's happening in one place to learn things for their own organizations. And then there were many examples of where when people were harmed and families were left with a bereaved state, that they weren't told anything. Barriers came up against them. There was resistance. There were lawyers sent to talk to them rather than the people that had been involved in the harm. So there was a condescending attitude taken to the victims of unsafe care. And then the 5 most dangerous words in healthcare. If you're a patient, you wouldn't want to hear a CEO of a hospital say, "It could not happen here." That sort of arrogance that we've nothing to learn, we're free of all risks, is the sort of environment and culture where it isn't safe to receive your care. So that was the state of the healthcare worldwide at the beginning of the 21st century. In the field of patient safety, there was disinterest, ignorance, apathy, condescension of victims, and even arrogance in believing that you had nothing to learn. And this is the battle that we've had to turn patient safety from being this fringe activity and resistance in the system to something which moves forward in a proactive and meaningful way. Very helpful were what have become known as prevalence surveys. As an epidemiologist myself, please don't task me on the use of that term, because it's not strictly correct, but basically these were studies where people tried to estimate the amount of healthcare that was associated with harm. So the very first study was done in Harvard in the USA and came up with an estimate of 3 to 5% of all hospital care episodes were associated with harm. Now, the definitions were quite tight. The methodology was purely on a medical records review, so you know, we would all know that things are not always entered in medical records, so we would probably see an underestimate there. And it was very much based on the negligence dimension, so again, the more minor things probably wouldn't have been recorded. But so subsequent studies that have been carried out in other parts of the world, shown on the slide there, have also come up with estimates. We don't tend to read too much into the differences, because these were broad-based studies using medical records, slightly different methodologies, and so the consensus among experts has been, if you want a number, take 10%. So 1 in 10 of all hospital admissions result in some form of error, some of which leads to harm, and some of which leads to very serious harm. And these are the sort of numbers that have come out of the prevalence study. So that helped to establish that this was a serious problem. And if there was a league table of burden of disease and problems, patient safety would come up relatively high compared to some other things. But it had never been a concept before, so it wasn't in any league tables. The concept of safety is really originated around the turn of the century. Now, very much in parallel to the use of statistics to try and show the burden of harm, from the very beginning, the WHO Patient Safety Initiative has used the stories of patients and families who've suffered harm alongside the dryness of the statistics. And this case, which is originated in the UK, has been used over and over again in presentations that I and other people have given around the world. It's been used in many of our reports, and it allows the not just the human side of safety and risk to be illuminated, but it also allows one of the fundamental core concepts of patient safety to be developed. So in history, our history has been one of using what might be thought of as unconventional means from the start. That traditionally, global public health programs use data, statistics, ratios, rates. They do not talk in depth about personal experience of those who are suffering from the problem, but that was one thing that we did differently from the word go. And this case particularly is a classic medical accident. So if you want to understand why things go wrong, then it's a very good example to choose. The boy was called Wayne Jowett. He was a teenager. He was being treated for leukemia. His prospects of survival were very good, but he'd missed some appointments for his treatment. And so he was persuaded by his grandmother to go to the hospital. She had the most influence with him. And he went one snowy morning in January 2001 to his local teaching hospital to receive his therapy, which he'd missed for the past couple of months. And he went out of sequence. He was no appointment, and the staff rallied round to give him his treatment, even though he didn't have an appointment, because he needed it. In any other industry, dealing with something outside normal procedure or sequence would raise a red flag. You're immediately into a high-risk situation, almost whatever the industry you're in. In healthcare, we don't think like that, or haven't thought like that. The boy was to be given 2 injections of different drugs, one into his vein intravenously and one into his spinal fluid intrathecally. Those were the 2 syringes at the time. They look similar. They contain similar amounts of clear fluid. That was how the drugs were presented at the time. One of the syringes, which was intended for injection into a vein, was specifically labeled not for intrathecal use. Do not give into the spinal fluid. And it was well known that that is a serious hazard if that were to happen. He was given 2, the procedure was carried out by 2 doctors, junior doctors, one giving the medication and one assisting. And what happened was that the wrong drug was given. So he was given the drug intended for intravenous use into his spinal fluid, and he became paralyzed and slowly died, what can only be described as an extremely painful death. I met his parents 5 years later to discuss with them their experience, and they allowed their interviews to be recorded. But his mother told me that she went to the intensive care unit when she was called into the hospital, and he had only one question for her: "Mum, am I going to die?" And she described the experience of telling her own son that he was going to die, because that's what she'd been advised. There have been something like 100 cases of this sort worldwide. The last one was in Hong Kong a few years ago, before that in Southern California. So things happen very similarly in different parts of the world at different times. The experts call it an error trap, or in less jargonistic terms, there is a common cause and a common opportunity for prevention. Now, this was investigated by a non-health accident investigator in the UK. The first time we'd appointed somebody who was experienced in accident investigation rather than in medicine and healthcare. And his report is in the public domain. And he did something which had never been done before in healthcare, incredible as it may seem. He did a reconstruction of the incident. And from that, he learned that a number of steps along the route had been responsible for this boy's death. But before I do that, I'll briefly show you this metaphor for thinking about safety. It was devised by Professor James Reason, who has helped the WHO program. So we brought in a bit of history again. We brought in some of the world's top experts including James Reason, to advise us. He's now an emeritus professor. He's retired. And it has the metaphor of the Swiss cheese. Slices of cheese are the barriers which protect people in different high-risk situations. And if there are holes in the cheese, it's the vulnerability for things to go wrong. And Reason argues, and the research evidence shows, that the liability for things to go wrong is more often to do with problems in the background, the environment and the organization of care, the so-called system, than in willful negligent actions by individuals, which are much less common. So the circumstances of a Swiss cheese with holes in it provokes error. It makes it more likely that if you're an honorable, conscientious person, even despite being conscientious, you will be provoked to make an error. And if you make an error, it will have a higher impact. Now, I show the Swiss cheese in Switzerland with some temerity, because the last time I did so in the Geneva hospitals to a medical conference, two irate elderly Swiss gentlemen came up to me and said to me, "Swiss cheese does not have holes in it." So this is a metaphor. It's not intended to go down into the cheese shop and see something exactly like this. So if there are any irate individuals, I advise you to calm down. It's better for your blood pressure, and you don't need to get angry about it. So if we look at the case of Wayne Jowett and develop this metaphor, how do we understand the system? Then in his case, I've given 4 examples of barriers that should have been protecting him. So as a patient going into hospital, there should have been strong procedures. There should have been physical barriers. There should have been well-trained staff. There should have been supervision of inexperienced staff. And all of those things and many, many more would have been protective barriers, stopping him from being harmed. But in each case, the investigation showed there were erosions to those barriers. There were no clear protocols for the administration of cytotoxic drugs at that time. The drugs looked the same. They were sent to the clinical area in the same plastic packaging. They were stored in the same fridge. It was very easy for them to get mixed up. So the physical design of the system was poor and liable to error. The 2 junior doctors carrying out the procedure, one had done one before and one had seen one before. They weren't well experienced, and the irony was that the doctor giving the drug was on an induction period when he wasn't supposed to give any clinical care. He was learning and observing. But because the patient didn't have an appointment and the arrangements weren't there to treat him, he stepped forward in a positive way to say, "I want to help this boy and give him his treatment." At that moment, he was stepping across a red line and he didn't realize it, because there was no red line drawn on the floor, either literally or metaphorically. And then a message was sent to a senior doctor to come down and supervise the procedure, but the telephone message got lost. So the supervision barrier was eroded, and that was why Wayne Jowett was killed, and similar things will have killed dozens of patients around the world. It's a rare event, but it's a classic accident. And what the history of the global movement shows is that we have used these case studies more than we've used burden of disease statistics to teach people that there is a new concept here which wasn't understood in healthcare. It's not only about the individual, it's about the system that lies behind them. And that awareness is something we set out deliberately to raise. Now this, I'm going to show you a very short video clip. It's from a training video that we produced. And if it doesn't work, I may need a bit of assistance because we've had some problems with it. But let me see. I think I can get it to work. Can we? What do I do?
Is this the one we tried before? No. Okay.
Usually you just click on the screen.
Yeah.
No,
So this
you've gone on a slide.
Yeah.
It's in the video folder. Pardon? It's in the video folder, so if you want to try. It's worth the waiting for. It will take just a few seconds. It plays only for a minute and a half.
And then when we play it, we'll just turn this off so it doesn't squeal.
This chapter 2, English New Modified. Do you think that's it?
It should be alongside my presentation. Yeah, okay, try that. Okay. Yeah, it's working.
So let me just turn this off.
For those of you watching on the web, for technical reasons, we couldn't get that shown to you, but we will show you, we will provide a link afterwards so that you can watch it. So that was a training video that we produced, which is much longer, obviously, and has got lots of moments that can be stopped and teaching questions asked. And the advantage of doing this is really to, if you like, round off the story of patients using the stories of victims of healthcare, is that when people see this and interact with it, it moves their hearts as well as their heads, and it really changes behavior. I showed this quite recently in Australia, and an oncologist came up to me afterwards and said he'd been involved in that incident, and he was in tears from watching the video because of the power of the terrible memory he had of the patient who was harmed. And we've also, as a result of that, we've created a program led by patients and family members who've suffered harm. Margaret Murphy is an example. She was one of our patient safety champions. Her son Kevin died in the healthcare system in Ireland due to an avoidable error. He went for a year with a raised calcium level in his blood, and this wasn't discovered due to yellow post-it notes with the lab results which went missing, tests that weren't carried out, results that were not looked at, and eventually he died. And Margaret Murphy met a wall of resistance. Nobody would tell her the truth, and she fought her way through and found out the truth. And with great credit to her and many of the other family members around the world who've helped us with this program, they have set to one side their personal bitterness and grief and anger at what happened, and they've come and to help us. The Patients for Patient Safety program is a vital part and has been throughout our whole existence. We have had many, many facets to our program: research and knowledge, promoting certain interventions, programs which have reduced specific causes of harm, but a key part of our work has been building global commitment. And to do that, we've created networks of international experts in areas like infection control, safe surgery, education. We've produced evidence-based standards. We've ensured that knowledge is gathered and then shared. And then we've, as far as we've been able to, promoted and tested innovation. We've had two flagship patient safety challenges. At the outset, we thought it wasn't good enough to set up technical programs and to have the resolution. We wanted something concrete that people could do to advance progress within particular fields of safety, and we wanted things that spanned the developed and the developing world. So the first initiative we took was healthcare infection. The flagship element of that, though not the only element, was hand hygiene. It was led by Professor Didier Pittet in the University of Geneva Hospitals, and Benedetta, one of our officials in WHO, has been the co-lead of this program. Clean care is safer care, we called it. We know that healthcare infection is a big problem worldwide, both in high-resource countries and also in low and middle resource countries. One of the challenges, one of the markers we set in this challenge was to get health ministers worldwide to sign up publicly in front of their media that they will give priority to reducing healthcare infection in their countries. And we did launches all over the world, and eventually 89.3% of the world's population was covered by these ministerial pledges. So you may say, well, what does that mean? And obviously it doesn't necessarily mean action, but it is quite a big credibility thing for a health minister to sign up. And that was just the first part of the program. Detailed work has gone on to mentor and provide tools to healthcare systems to prevent infection. We've had particular initiatives on hand hygiene. As many of you know, the basic level of hand hygiene amongst medical and nursing staff is relatively poor. It's down 20–25% compliance in some places. And we've done evaluative work to try and show which interventions will improve compliance. And these are just some of the countries that we've worked in. The second global challenge of safe surgery, led by Dr. Atul Gandhi of Harvard University, set out to acknowledge that surgery is as common or commoner than childbirth worldwide, and it causes a lot of harm. And the innovation that we piloted there was the idea of a surgical checklist, rather like would be used in the airlines, a 1.5 to 2 minute before, during, and after checklist to make sure that patients are the right patient, because we know from incidents that there's much wrong site surgery carried out around the world. Patients die unnecessarily because they haven't had prophylactic antibiotics or anticoagulants if their case merits it. Are the instruments and swabs correct? Because many incident reports show retained instruments and swabs. So to get all the team together, go through the checklist, even though they may have done it 100 times before, make sure that everything is checked. And the early pilot studies showed a reduction in death. People were cynical and saying, well, it's a very small scale observational study. But a subsequent much larger study in the Netherlands has replicated that and led the New England Journal of Medicine editorial to say this: checklists are not the final step towards optimizing surgical quality, but in the meantime, checklists seem to have crossed the threshold from good idea to standard of practice. So we've seen the checklist implemented around the world, and that is progress that is very, very important. But we have also have anecdotal impression of reluctant clinicians or resistant clinicians who, in a minority of cases, don't want to play a part in the checklist. So there is still a challenge in changing the culture as well as changing the practices. The two things go together, of course. The Patients for Patient Safety program I've mentioned. We have many patient champions around the world, but the other aspect of this, of the power of the victim to change things for the better and make healthcare safer, is what does it take within an institution, a big hospital, for things to change. And this is the story, and it's just one example. I'm coming towards the end of my presentation now. It's one example of a bad, very bad, tragic incident which then led to a massive change in the culture of that organization. This is a woman called Betsy Lehman. She was the health reporter of the Boston Globe newspaper. She'd been treated for breast cancer. She'd had a harrowing course of chemotherapy at Boston's Dana-Farber Cancer Institute, and she was due to be discharged, and a nurse found her waiting to go home, sitting by her bedside, fully dressed now, weepy and anxious. Betsy had phoned a friend, a hospital social worker, but she'd got an answering machine, and she left a message which said this: "I'm feeling very frightened, very upset. I don't know what's wrong, but something's wrong." An hour later, after leaving that message, she was dead. Her doctors had mistakenly prescribed an overdose of a powerful anti-cancer drug, 26 grams instead of 6.5 grams over 4 days, and the mistake destroyed her heart. Pharmacy screening beforehand had failed to prevent the error. An autopsy didn't show the mistake. It was only while someone in the hospital was preparing to publish some clinical data that a data specialist discovered the drug overdose. And he also discovered another error that had gravely injured but didn't kill a second patient. So Betsy Lehman was the victim of modern medicine, the type of modern medicine that's supposed to heal you and not kill you. But she died due to a medical error. And you can imagine the furor that was caused, particularly in the local media, when you kill the health reporter of your local newspaper. The newspaper raged against it and the poor quality of care. And the Dana-Farber Cancer Institute was under the cosh in a big way from the regulators, from the public confidence point of view, and from the media. But over the period of 2 years, it transformed its culture and its ways of working. Families and patients are embedded at all points in the hospital, in the board, in the planning committees, in the design of services, in the feedback, in every aspect of the hospital's work. And every member of staff in that hospital knows why this is being done. It's being done because they don't want to ever have another case like that. And so if you wanted to go to a place which is as patient-centered as you can get, go to the Dana-Farber Hospital, but go there and know that they've transformed themselves because of a serious patient safety incident. The great puzzle to us in the program is why that sort of transformation doesn't happen everywhere that there are serious tragedies of unsafe care. Because the minority of places change like Dana-Farber, but many have such things and they don't transform themselves as a result. And it reminds me of one victim I spoke to in Canada, where she told me about her child who died due to a medical error. And she said, I went to the hospital and they offered to do something in my child's memory. And she said, I don't want a plaque. on the wall of the ward where he was treated. I don't want you to plant a tree in the garden. I'll tell you how I want you to honor my son's memory. I want you to honor it by showing that you can learn. And essentially, it's that process of learning that remains the fundamental challenge for the global patient safety movement. We've shown we can raise awareness. We've shown we can move patient safety from a marginal interest of academics and experts into the mainstream. We've shown we can make it a priority for many healthcare systems around the world. We've shown that we can collect data. We've shown that we can bring the stories of victims and empower those who've suffered harm and ask them to lead programs on our behalf. But we have yet to show systematic reductions in risk in some of the key areas. The learning has not yet taken us to the point where we can intervene to produce sustained reductions in risk. And that's why patient safety continues to be a priority and a challenge, and that's why everybody involved in the program here in the WHO and elsewhere in the world are fully committed to doing that work to honor the memories of all the people who've died unnecessarily from preventable harm.
Thank you, Sir Liam, for your presentation. Before we take any questions, I'd now like to ask Dr. Edward Kelley, who is coordinator in the patient safety program here at WHO, to give an overview of WHO's activities in this area.
So when I was very kindly asked by Human to represent the program and have a word here, Liam and I spent a bit of time on the phone talking about how we would divide up some of the discussion because sort of the history that Liam has with patient safety as one of the, he said it was okay because he technically is this term, to use the term grandfather. He is one of the grandfathers of the movement, but that I was hung up the phone with him, and being from New York and being a baseball fan and liking pizza, Yogi Berra is one of my favorite people to quote. And at one point, Yogi Berra was meeting for lunch with one of his favorite pitchers for the Yankees, and they agreed they were going to split a pizza. And Yogi said, "Look, don't cut the pizza into 6 pieces because I'm just not that hungry if we're going to split it. Cut it into 4. So for those of you, take a minute for that to seep in. Those of you envisioning a pie chart. Anyway, so there's just only so much history on patient safety, a relatively new discipline that Liam and I can carve up amongst ourselves for 6 pieces in the slice. But what I thought I would do, jokes aside, is to present just a little bit of the Liam situated the program and the history on this. It's just to provide a very brief view forward of some of the challenges that we face within the program itself and how to sort of tackle those. The 3 things I'd like to touch on are just the new strategy, kind of generically speaking, that we have at the World Health Organization on patient safety, highlighting the fact that the Director General, for the first time, mentioned patient safety in hospitals as one of her priorities in her next mandate. Touch on what I guess I would term the 3 worlds of patient safety and quality, and then end with kind of 4 challenges. The new strategy for patient safety, there actually does exist a document that was begun under Tim Evans and then carried forward with Mary Paul Keeney, and very ably, although I'll thank him more profusely at the end, with our acting director, Najib Al-Sharbaji. And it touches on 3 particular areas. When we started, Liam mentioned this in his presentation, we were really looking at a sort of a range of issues of getting patient safety on the agenda for national governments providing information on the scope of the problem, on sort of prevalence. So we tend to use the term burden these days, which is not perhaps technically correct. Looking at solutions, developing those into challenges, and engaging patients. It's not that our new strategy steps away from those, but the way in which we would do it is quite different. The new strategy emphasizes three particular streams: providing leadership in patient safety, harnessing knowledge, expertise, and innovation, and engaging healthcare systems, NGOs, and civil society. Now, in a lot of ways, that could be a generic description of a number of departments here. So I'll go through a few points on how these particular streams of work will play out in the coming period for the patient safety program. In order to understand why we would even come up with a new strategy, I think it's important to realize that the world, generically speaking, of patient safety and quality is quite different. Now, Liam alluded to this. When we started, as someone who spent his whole career working in mostly quality improvement work, I did my doctoral work in Niger, West Africa, looking at improving compliance with IMCI. I worked with the U.S. government on generic work on diabetes and preventing diabetes, ensuring adherence to diabetes prevention standards, preventing heart attack work, and documenting that with the U.S. National Healthcare Reports, and then also with the OECD. The issue of quality is one of those, as you would say in America, to continue my overly American-focused allusions, a sort of mom and apple pie issue. That is, no one's against mom and no one's against apple pie, except those of you with gluten allergies, I suppose. But the issue of quality also was not one that it didn't inspire people, it didn't grab people's attention. It was, as a journalist friend of mine who worked for the Washington Post called, a thumbsucker issue in the media. There was just sort of no hook. You couldn't create a villain, victim, and resolution. And that's not the goal for public health, but it does make it difficult to get noticed on national agendas. Now, sort of 10 years on in this work on patient safety, you really have kind of three different worlds in terms of the countries we work in. The first group of countries I would call the early adopters, which is in terms of diffusion of innovation theory. That's well known to most of you in the room. But the group of countries that moved on board with looking at patient safety as a national issue. And there were a number of reasons for it. One, many of them had well-resourced national research funding institutions who were willing to put money out there in frequently very large grants for research. They had active academic institutions and an academic field, healthcare services field, and they also had very active press and media. And Liam highlighted just a few examples of where actually reporters being injured spurred quite dramatic changes and examples of dramatic changes. And all of those played into these countries' leadership and work in patient safety analysis. The numbers, while essential, they were not sufficient. It was also those contextual factors that placed these countries where they were. Now, one other fact that deserves mention is that if you look at all these countries now, many of them are struggling to keep safety on the agenda. In fact, now these are donor countries for WHO. We're very lucky in the program in that we interact with some of those directly, not because the patient safety is an issue for development or for USAID or DFID or these countries, but it's a domestic issue for their ministries of health. Unfortunately now, if you were to look at this list, the United Kingdom, the National Patient Safety Agency, has been abolished. The United States, work done over the past 7 or 8 years has been sort of wound down with, under President Bush, the Patient Safety and Quality Improvement Act was the last major act to really look at safety. In Canada, the Canadian Patient Safety Institute has scaled back its operations and is not doing very much internationally, save with us. They're in danger of achieving their reauthorization. Netherlands, where I just was recently, patient safety as a national strategy is being moved off the agenda. So I think there's a cautionary tale for us in looking at these countries. At the other end of the spectrum, the end of the curve, you have, and I've just listed, these are not obviously an exhaustive list, but these are some of the countries we're actually working with who are at the end of the curve in terms of Mali has lots of political problems just currently, Niger, Senegal, and much of Afro. Patient safety, there's not even sort of a unit or an individual designated within the entire Ministry of Health to tackle quality, much less patient safety. And one of our colleagues who advises the African partnerships on patient safety, Dr. Sam Zaramba, former member of the executive board and sat with Liam, said, you know, when we first started this, I think directly to our program's previous director, something, you know, look, we can't tell people that we are killing them. In Uganda, we're having trouble getting people to come to the health centers. This kind of work in other countries, Bangladesh, Afghanistan, Cambodia, and others, is in a similar state. The middle majority, I guess, of these countries is where I'd like to focus a bit of attention. These are the countries where, surprisingly, pardon me, countries like Qatar, Saudi Arabia, Norway, others, where we see an agenda being developed, surprisingly, behind some of these others that focuses on particular issues. For instance, in Norway, they're interested in reporting in learning systems. In Finland, on national strategy development. These types of activities change from, you know, sort of region to region, Nordic to the Gulf to Asian leaders, but they're all involved in some sort of specialist activity and looking to connect to a broader world of patient safety information. And in many of them, Qatar included, Saudi Arabia, the issue of just building capacity, sort of a general idea that we should be doing something in patient safety because the rest of the world is doing something in patient safety, is the predominant feeling. Now, if I can just come to the fourth rail, which is probably not the right number for when people generally refer to these rails, it's usually the third rail, except in some dysfunctional train systems, I suppose. The private sector is one of these untouchable topics in WHO until very recently, and you know, lots of that is for good reasons. But we have begun work now on engaging the private sector. It started with a relatively narrow focus around companies involved with healthcare-associated infection and alcohol-based hand rubs. We are a small group, as most of the departments here are, you know, numbers-wise. The firms that are working just in this relatively narrow industry outnumber the people visiting hospitals, outnumber us by 100 to 500 times, and the amount of money that they spend on their work is in the same order of magnitude. We are launching this 5th of May a platform that will allow us to work with these private companies, resourcing some of the things that we need to resource here from the Secretariat and common projects. Here was at the right is a piece of a guide that caused that sector of the economy to be furious at us. It was a guide to local production of alcohol-based hand rub. They loved us when we came out with the guidelines saying you need alcohol-based hand rub. They hated us when we told countries how they could do it themselves. So now we're working together with them. And just before I move on to my last bit on the challenges, you know, the issue that we've come to in many of these countries, to return to why things are stalling in some of these countries, is, I think it's manifold. I mean, a lot of it has to do with finances and the cyclical nature of the, you know, finance availability that we find ourselves in a difficult place in now. But a good portion of it is that we started this whole journey with the idea that we, in a certain amount of time, in some countries we said 5 years, in some countries we said 10 years, in many countries we set targets. Finland is just about to have to report on a 50% reduction in preventable events, which they will never be able to do, although I did not say it in that direct terms when I was just there. But in any case, almost all countries had some goal of making healthcare safer, naturally. But now policymakers are coming back to us and saying, are we safer? Would this Vin Christine event not happen now? And the honest answer is we cannot say. In most of those countries where we started work, where generically we as a community of people interested in safety and quality started work, there was a lot of efforts around those initial prevalence studies. Then there were systems, reporting and learning systems set up. There were efforts to looking at root cause analyses and data analyses, efforts such as at the OECD worked on the Healthcare Quality Indicators Project to look at data sources, developing discharge data for potential analysis of safety problems. And in most cases, the data is ill-suited, such as in the OECD's case, for analyzing this problem. And discharge data was meant for reimbursement, not for looking at quality and safety. Or the reporting systems were developed by, and I don't know if Liam would agree with this, but methodologist enthusiasts, if I can squeeze two words together, who were extremely enamored with the different statistical ways they could get and crunch data, but without a healthy outside check on whether they were measuring the right thing and what weren't they measuring. The bottom line is, for safety, we're measuring things that people don't want to tell us about and things that are quite rare. So both of those mean that initially, most of the time, numbers went up as people figured out how to better measure patient safety. Since then, we've been making progress in some areas, but only in areas where there have been concerted national efforts to really tackle the issue. So to wrap up, I'll mention 4 challenges, I think, for the program. Liam showed this slide initially, but I use it just as an example of the re-engagement that we need to do. We had broad engagement on our first global challenge and on our second global challenge with countries. Part of that was due to a massive effort we made. Part of that was due to Liam and Didier's and other people's willingness, and Alpha Grande's and other people's willingness to fly around the world and see people. We're no longer in the position of being able to do that. So how do we re-engage national governments, both on a local level and internationally, to have some of the results like we see in this slide? Some of that will be around providing that leadership bit, but in the policy and strategy arena. There's never been an effort to really look at sample legislation and sample policies and really talk about what works and doesn't work in that arena internationally. And we have an international colloquium at the Global Salzburg Seminars, which Liam will be helping to lead this April in a couple weeks' time, which will then provide some information for meetings that we'll have later in the year, including the World Health Assembly. We have a technical session at 12:30 on the 23rd, so I hope to see you all there. And also the International Society for Quality in Healthcare, which is the main professional body working internationally in quality, is meeting here in Geneva this coming fall. The next bit for us in terms of challenging ministers will be our third Global Patient Safety Challenge, which will focus on the issue of medication safety. Clearly that will involve a number of pieces of WHO as we move forward with that, and we start to hone down exactly what the challenge is. I think the issue here, I have the fortunate or unfortunate luck to have a brother-in-law who got his PhD in aquatic resonance. So I have many holidays where I hear lots and lots about bubble theory and wave theory and ripples. And one thing I've taken away from that is that there is, very interestingly, a growing body of evidence in aquatic resonance theory, something I'm sure we can have the next brown bag on, that bodies of water and air and others actually can develop a certain memory for ripples. And the issue that we have, if we're not able to throw huge rocks into the large pond of global health all the time, is how do we keep those ripples going by just throwing small pebbles in as we go along. And we had, for instance, with the Global Patient Safety Challenge, periodic pebbles thrown in every 5th of May to remind people that we're out there, to ask them to tell us their stories. And in most cases, they don't really want us to do things anymore. They want to do it themselves and have us listen to it. So I think, anyway, that's a lesson for us for the future, I think. The other way we are doing it, because there's no getting around it, is to do some direct work with countries such as those on the late curve, where there's just not the resources for it. And our program, it's not the only program working in Africa. We've had research work in Africa, a very good article just coming out recently in the British Medical Journal on this, led in part by Itziar and others. But it's the African Partnerships for Patient Safety Program is looking at partnership programs between Northern Hemisphere countries, and actually also Brazil, and African hospitals to try and advance a range of issues in 12 different action areas. And I think that's, again, an area where we are encouraging action, but by bringing other people together, not by necessarily leading it ourselves. The next challenge we have, really, I think, if you look at that mass of countries who are in the middle, the kind of the middle majority, that is building capacity. And it's the same problem that a whole range of programs here at WHO face, especially a lot of those countries have very migrant workforces, very different credentialing standards, but work on, such as this multi-professional curriculum guide that we had that was released earlier this year, and other tools like it will have to be a focus. This just highlights the award that it got this past year, and I think that one of the keys to it will be moving into an electronic environment as we move forward, and luckily we'll try to move that forward while we're still associated with the KMS and the eHealth group, so we can get free use of the department before we move on to our own strategy. Third challenge, innovation and empowerment is a word that's heard frequently in our current cluster, IER. It's a theme for our current Assistant Director General. But this idea of value-based innovation is something that I think the Patient Safety Program will really have to emphasize. We have a tool right now that we're working on. It's a phone-based tool for mothers. The idea being here that it's paired in some ways. We're looking at pairing it with our safe childbirth checklist that's just started, which I'll come to in a second, where handover management and information for decision making after and during the 7 critical days after delivery is something that is a big complete gap in healthcare delivery in many countries, and it also leaves room for adapting other tools for patients in this realm. And I think here, well, this is one example of it. What we're really talking about is not necessarily kind of the next gadgets or coming up with an mHealth tool because everyone likes mHealth right now, but it's getting back to that core message that our DG frequently speaks of, which is that mostly, and probably 85 to 90% of the time, we know what to do. It's the issue of getting people to do it. So we know what should happen when mothers are bleeding post-delivery. But getting them to come back, giving them the tools, a validation tool to get them to come back is the trick. And I think that we have often in the safety world approached this from the supply side uniquely. So only for providers and sort of increasing training. We haven't done enough for the patient side, and they're the only ones, as one of our colleagues on the Patients for Patient Safety Program would say, who see their care from start to finish. And involving them more is something that we need to do. And I think the last challenge for this, and I'm speaking about WHO because that's what I was asked to, but it's generally speaking, safety, its strength when it started was that it was a specialist program. It had a narrow niche, and it was able to really come up with a concrete issue that people could get behind. Everyone agreed that we should wrap up that we should address patient safety problems, and that people shouldn't die. The issue was moving that from a specialist program just about this narrow issue to a broader question of quality. We have an article coming up, we hope, in the bulletin, and the issues of moving into safe childbirth and vaccine areas will be ones that we really need to address. This is a quote from our regional focal point based on the work done to prepare for in September 2008 in Yaoundé. We will have to make a transition from safety as a specialist issue into a health system strengthening issue. That will end up being our future. I'll conclude. I don't know if people, some of you in the room here are fond of these books, and they're frequently posted over there on the bulletin board. The Heath brothers have come out with a number of these, but this book, Made to Stick, was one that I think encapsulates a number of the issues that patient safety really needs to deal with. 6 principles of sticky ideas. I won't go through them all, but I can recommend the book to you. But I mean, this could work for any of the work that you're actually working on. That if you want something to stick, it needs to be simple. You don't want a soundbite. You want a proverb. That's their guidance. It needs to be unexpected. The issue that in the States, as Liam mentioned, the numbers crunch made medical error the 5th leading cause of death. It was something people were blown out of their seats about. It needs to also be concrete. How do we make it real? And this is where 90% of kind of big efforts and big challenges go wrong. The final bit on credibility, which I'll just say one short word about, is that there's a tension, as I mentioned, between the enthusiasts out there. Patient safety had become, when it started, a real mission, and the appropriate level of self-examination was not really done. We have a big gap right now still with looking at what interventions make a difference. And in the U.S., for instance, when we had examinations of research problems on diabetes interventions, my own institution, the Agency for Healthcare Research and Quality, concluded with an evidence-based practice center report that nothing actually was working in improving compliance with major diabetes interventions, which we know is not true. But it's the research, the standards of evidence review were not well suited to the review of those particular interventions. And it's doubly true for safety, and that's something we need to tackle. And finally, the issue of stories is how we get emotions in stories, is how we get people to act. These are 2 quotes, one from a woman in Uganda that she likens the treatment that they have from their doctors to being like farmers, saying that doctors treat us as if we're plants. They care for us, water us, and help us grow. But in the end, they're like farmers. They care for us for their own purposes. How can it be that they're working for us, but they do not talk to us? And this is from a man in the U.S. My mother lay dying in the intensive care unit from an infection she got at her hospital. Why was no one telling us what was happening? On the final day of her life on rounds, the whole clinical team came in and talked only to each other while we sat there looking at them, wanting to understand what was happening. Now, these are 2 individuals, a world apart in terms of resources, experience, and background, but there's something universal in the way we train doctors and deliver health care that makes those 2 individuals, if they got in a room, they could tell the exact same story about the health care they received. And I think still coming back to that basic story that Liam mentioned is something that we're going to have to address. So I'll conclude with that and just thank Sanjay and the York team who worked with him to help put this on, especially Human, who faithfully advances us. We were amazed to find out what number we were actually on in terms of the Global Health History seminars, and also the information that I got for the presentation from Itziar, Benedetta, Gerald, Shams, and Agnes, and also certainly to Najib, who has faithfully led us at leading both departments that house the Global Health History Seminar as well as the subject of today, patient safety. So thanks very much.
Okay, so I will hand over now the session to my co-organizer, Dr. Sanjo Bhattacharya from the University of York, who will coordinate the questions. And actually, it's a 60-second seminar. I made a mistake in my presentation.
Okay. Thank you. Well, thank you everyone for coming. For the benefit of colleagues who are listening to us over the webinar, when you ask questions, can I request all of you to identify yourselves? So it is being recorded, the event, and we hope that many medical students will be able to download this resource and use it for their own work. So I'll start with proceedings by saying I'm Sanjay Bhattacharya from the University of York. I've been working with Najib and Human, a Global Health Histories project, for several years now. I'll start off with a general question, and then I'll throw the questions open to the floor. Ed, at the very end, you do refer to the regional office. I'm just wondering historically, and we're talking about very recent history here, whether there are patterns of responses that one can map in relation to the different regional offices responding to the plans you were setting forward. But also the country offices. I do realize that some countries do not have offices. But, you know, just from my work on India, what is very apparent is that the country office seems to have much more is much more close to the health department, the federal health department, than it is than the regional offices to the Indian health departments. I'm wondering what role, what responses has the WHO patient safety recommendations had from the country offices that you deal with. So thank you.
Well, I'll make a quick comment, and Liam may want to comment on when we first started. I think it's changed quite a bit over the history of the program. Again, when it started, it was a specialist program grown out of a WHO headquarters resolution, and it was really driven, and it still continues to be driven from here. It was only during the early phases that we got a regional focal point designated. Then at a certain point, we started providing some support, salary support for that person. So invariably, that got you noticed by the regional director that you were helping support them or sending them some money. So those things helped. But it's really quite a varied pickup. I mean, it was quite focus in Euro and PAHO, and then in EMRO, because in both PAHO and EMRO we had these we had prevalence studies that we were working with a number of countries on, led by our research team. And it was quite quiet in WIPRO, very quiet in AFRO. But conversely, sort of now we see those regions, WIPRO, AFRO with African partnerships, and EMRO really taking up more, whereas activity is tailed off perhaps a bit in Euro. So I don't know, it's been a bit cyclical, and I think that's partially resources and partially the fact that focal points, even in the countries were designated, they were already sort of the blood safety person, the injection safety person, and so this patient safety idea came up. They said, well, they've got all the other safety things, just give it to that person. So it was added on as a. So anyway, that's a bit logistical of an answer.
Very briefly, I mean, essentially this is a program of change management, and I've been interested all my career and involved in change management, and sometimes we don't go about it in as organized a way as we could, but if you look at the way we've worked, I think the essential question is if we want to shape and influence the priorities of every healthcare system in the world, and also motivate and gain commitment of every person who has contact with a patient or organizes care for a patient, and that we can't personally do that because there are millions and millions and millions of them, what is our best route of influence through them? And I think what we've done is we've used the regional officers in parts of the world where regional officers are closely interfaced with healthcare systems. In some regions they are, in some regions they aren't, in some parts of regions they are, in some parts of regions they aren't. But in other places we've gone directly to leaders of healthcare systems, health ministers. But the other area that's worth mentioning that we maybe haven't talked about so far is clinical networks. So in the first challenge we have a very tight global network of infection control experts who really have had great influence, and similarly in surgery by bringing together the surgical doctors, the surgical nurses and the anesthesiologists, we've gained a great deal of influence within their own healthcare systems by getting a corporate global view. So essentially the question is, how do you influence the front line of healthcare in every country of the world? The answer is in different ways, sometimes through the regional offices, but also through other mechanisms.
Thank you. Catherine Brookman from WHO. At the outset, you mentioned that there are lots of structural factors that lead to these accidents. And I'm wondering to what extent in the change management process, sort of the aspect of insurance and third-party liability isn't also one of these structural factors that prevents sort of being more open about accidents. And by chance, on German television, they were showing incidents of patients who had instruments in their stomachs and so forth, or they were wrongly operated upon. And the lawyer was saying that in 25 years that she has defended cases, she hasn't had one single one that she's won. And they subsequently had a doctor who then said that they have been instructed for reasons of insurance not to say what has happened and that there was actually an accident. So it seems that there are also quite a lot of structural factors, not in all countries, but in several, where that plays a big role.
And if I could just respond briefly, I'm conscious of the time, so I'm going to keep my answers brief. There's a lot more I could say to such an important question. But essentially, one of the key philosophies of safety in healthcare or elsewhere is to try and create as blame-free a culture as possible. That doesn't mean there should never be accountability, but blame-free so that people feel that they can confidently report mistakes so that learning can take place. If there's a culture of fear and retribution, they won't report and then no learning happens. And I think you're right that some aspects of healthcare systems in some countries militate against that openness. The great irony of litigation is that the whole system of tort litigation whereby negligence is possible, the whole philosophy of it is supposed to be by demonstrating to people the negligence that someone else has caused and the punishment that they get, it will help them not to do the same thing. But the irony is that given that so many cases are settled out of court, the truth and the facts of these incidents never get into the public domain, so there is no sort of demonstration for the others of the punishment or the reason for the punishment. So I think it is a mess, and we just have to keep trying to push this principle of no blame wherever possible.
Thank you very much for this 60-second Global Histories Conference and to the speakers. I'm Susan Wilburn from the Department of Public Health and Environment, and I wanted to ask you to reflect on the link between patient safety and worker safety, both in terms of how you can engage health workers in promoting patient safety by protecting them from their own hazards, as well as what the linkages are between those situations that result in infections to both patients and health workers or exposures to hazardous drugs or chemicals in the workplace.
A really brief intervention for Liam. Clearly we could do a lot more. I think that actually if you look strangely at the patient safety literature, there's been there's quite a division. It really is not about, the patient safety methodologists have not looked at sort of the cross bit between occupational health and safety, rather in healthcare work settings and the safety to the patient. But it's been recently that you see more and more coming out about it. Sort of safe workers may lead to safe patients. There's links to health, sort of working hours limitations and those kinds of things. And there's some work that we're doing now in injection safety that trying to pair a demand for better injection safety for patients with needle stick injury prevention that would clearly benefit most frequently healthcare workers. But anyway, it's something that needs to be done quite a bit more, and better links between the patient safety program and Global Health Workforce Alliance and other programs here needs to be done. It's one of the action areas within, for instance, our African Partnerships Project. But
when I talk at conferences, sometimes people get irritated with the parallel with the airline industry, and I've had a lot of irate doctors that have stood up at the end, and they all say the thing, we can tell you why safety is taken more seriously in the airline industry. It's because the pilot goes up with his plane and the passengers in it as well, so they're all in the same boat. I don't quite know why that excuses healthcare for being more dangerous than it needs to be, but I think essentially the conceptualization of patient safety, as Ed says, has not particularly embraced the safety of the workforce or the staff. But I think you could argue that maybe the patient-centeredness of it is not where it should be. And one of the studies that was done on hand hygiene, where behavior was observed in trying to get these higher levels of compliance of hygiene, one study showed that doctors were more likely to wash their hands after seeing a patient rather than before. So in other words, they were protecting themselves rather than protecting the patient.
Rob Joe from Public Health Innovation and Intellectual Property. Thank you very much. It's very interesting and spoke to certainly my own experience of trying to
get an answer out of a hospital from a particular incident with my wife during childbirth, which was very frustrating, and exactly the answer that was given, we don't want to admit liability, so we're going to tell you nothing. But just listening to these stories and the power of the individual, and a lot of what you're talking about seems to be trying to change things from within, which obviously is the focus, okay? But that remains the hospital culture, the doctor culture, trying to change their behavior. And yet most of the actions, or the significant actions in the case studies you gave, were when individuals and patients made a strong case and maybe got the media involved and those kind of things. So just putting that together and listening to your strategy, I'm just wondering whether or not you've got any thoughts around, and I don't know what form it would take, but what you could give to individuals if they come across an incident and they want to try and do something about it. What do they do? Is there a checklist? Because I certainly found I had no one to talk to when I needed to make a complaint, apart from another family friend who was a doctor, so it was immediately a conflict of interest. But I was just listening to what you were saying, the power of the patients, the power of the press, and shining a light and those kind of things, and whether or not there's anything in that which could be something that you could look at.
I mean, I share your frustration, and one of the things about being sort of retired from my old job and now very busy with other things, incidentally, the World Health Day, healthy aging, the definition of middle age has been changed, I hear. I think it now goes up to 67, so I would rebut Ed's idea that I'm the grandfather of patient safety. But I think, I mean, one of the things I find is being medical, although a long time after, I'm constantly approached by family, neighbours, friends with their stories of problems in the healthcare system. And the thing that strikes me is it's back to this urge that providers of healthcare have to classify something as a one-off. You know, oh, we're very sorry, you know, that this happened. It's very rare, and you know, things like this just don't happen. But we've learned every possible lesson. I find the opposite, that in any incident there are some very local factors that probably are unique to that institution, but very often there are fundamental cultural things that have to do with the healthcare system as a whole. And it's a deep source of frustration to me when I talk to policymakers that they just don't seem to get it. They don't seem to realize that if they harvested all of these things and distilled the generic messages and lessons, that they could completely transform their healthcare systems. But it seems to be something about the way that people are prepared to learn and act on information that's a problem. But so I share your frustration. The only answer I've got is that some of us are trying very, very hard to ensure that happens. But on a more specific point, there are some systems where family members and patients are encouraged to report not through the complaint system, although they still could, but through the incident reporting system.
On that, I think that there has to be two problems. I mean, the issue that you see now in forward-thinking safety efforts is that safety and quality efforts is that it's rather than just having energized patients for having energized patients' sake, which actually we're guilty of ourselves having this great network, and now what do we do with them, is developing tools for patients where they could be mobile phone based like that, or a range of other tools. And so countries like Denmark and others are focusing on that. There are some recent publications, books that are out there. There was one that was just published and reviewed in the New York Times on a checklist for your next hospitalization. But I think that where you see real leading institutions, for instance, Liam and I visited University of Illinois Chicago, where their reporting system, they do have some information for patients, but their reporting system has a guarantee they have 24 hours to turn around, report back to the family on any serious incident or near miss. So when you have that clock ticking, as soon as that comes in, and you know you're going to have to be in front, this is how the chief medical officer explained it to us, you know you have to be in front of that patient's family talking about why this drug was misadministered, like that really generates action in terms of analyzing the data and looking, team gets scaled right away. So you do have to have structural changes as well as the engaged patients, I think.
Chris Veerasurya from Essential Medicines, but the question is more from the perspective of low and middle income countries. in low and middle income countries, the for-profit private sector is an enormous component of healthcare. How does one deal with this in terms of, sort of trying to get them to invest in patient safety? Because if in profit, they are looking for, well, what's the return and so on. Have you had any experiences in talking to them and saying that this is a worthwhile investment? Or is it the eternal problem of investing in public health? People are prepared to invest in the latest cardiac catheterization, but public health gets a very low this thing. And unless there is regulation and something that says you have to invest in this because this is going to give you public health returns, then only does the private sector sort of respond to some extent. I ask this because the private sector is an enormous component of for-profit private sector is an enormous component in the low and middle income countries.
Well, I think we probably can't say that we've specifically unpacked that issue and dealt with it, but what I can say is that in principle the private sector is much more susceptible to reputation damage. And if you take the example of Dana-Farber, which is partly in the private sector in the US, with all the work that it did, basically its market share fell after this Betsy Lehman incident, and with the work that they did and what they could show to the public that they had done to transform themselves and the day-to-day experiences of people, their market share has now gone up very considerably. So, that is a nice virtuous circle. Obviously that doesn't happen everywhere, but in principle there's no reason whatsoever why the incentive for the private sector shouldn't be a positive one.
My name is Manjul Joshipur. I work at WHO looking after the trauma care. I heard about the challenge of engaging and re-engaging the governments and the countries across the world. One of the tools that some of the WHO programs have used to engage the government is looking at the economic cost, and the most recent example is, of course, the NCD, that they have calculated the cost of what would be the cost to the economy in general. So I wonder, I'm just curious whether you had made any attempt at looking at the economic cost, because often in countries other than the burden of deaths, disability, and other standard health statistics, this can be a powerful tool for argument because countries are looking at containing the healthcare cost, healthcare budgets, and some of the growing economies across low and middle income world would also be interested. And other than that, there might be other partners in the UN system. For example, World Health Economic Forum partnered with our NCD program to look at the cost of the NCDs in general.
Excellent point, and it's one that we have not, patient safety program has not done that much work on outside of individual programs, but there's a huge economic cost. If you look at, for instance, we did work with colleagues from Johns Hopkins on eliminating bloodstream infections, and they took data modeling it out for one state in the U.S., then looked at what kind of impact that would have based on sort of number of catheter days and prevalence of these infections, and it numbers in the tens of millions. And you expand that to nationally, and it goes to hundreds of millions. And so there's a major case to be made. It's not made enough partially because of the difficulties of the sort of prevalence estimates in large part, but and it's country specific because readmissions in the United States or length of stay in the United States are very different than in other countries. But there's a lot of basic analysis that could definitely be done for sure going forward, and I think it's something that in some new initiatives that we're looking at in collaboration with our SIGN colleagues on injection safety, that'll be making the business case. I think it'll have to be part of the piece that we go forward with. I mean, it'd be excellent for the work we're working on the trauma care checklist. That would be a major case for why this should be funded by a member state. But it's been something, like I say, it comes back to the enthusiasts having led the early charge on safety, where it was more of a mission. It was about how can we let this happen rather than we didn't really think we had to make a business case for not killing people. So but now, it's clear we need to move beyond that.
Thank you very much. My name is Regina Ongeder. I work for KMS with the Portuguese-speaking countries. And my question is a question and a comment in a way. You've been working with patient safety for how long now?
Just over 10 years.
So are you, right? I mean, during this time, you think that the statistics have improved? Do you think so? I mean,
look at are you wanting me to take this? Well, no, if you look at, for instance, the U.S. national reports that I used to direct, the one dimension of performance that they measured, they had 6 dimensions of performance. This was a report to the Congress and to the President about our healthcare, quote-unquote, system. And the one dimension of performance that did not improve over the time that we were directing it, the first 7 years that I was in charge of it, was safety. Actually, it was the one area that got worse at first and then eventually got better. And part of that, I think, some of that is data related about better systems as we started to understand how to measure these things. And some of it is that in the U.S. at least, and in many other countries, there was a tension between starting lots of initiatives, and people, like Liam would agree with this, in the UK it happened where people just got over initiatives, and then there was the problem of actually sort of being able to measure, the proper baselines sort of weren't done. So I think that it would be tough. It would be hard to say that the world is sort of, globally speaking, safer now than it was statistically. But for sure, the amount. If you look at we also looked at the amount of attention paid by media articles on safety and the number of safety initiatives that have been put in place. For sure, those have gone up. So it's impossible that things haven't gotten better, but right now we have a big issue to address in terms of improving the statistics, I think.
It's a very difficult question. I think what I say when I'm talking about it is that there haven't been major improvements in many of the examples that we talk about, things like wrong site surgery, medication errors, across the board, but there have been improvements in some places where you can demonstrate large teaching centers, sometimes in countries. Some have done exceptionally well in reducing healthcare infection. Some have done exceptionally well in reducing medication error by bringing in electronic prescribing and other mechanisms like that. But if you ask the question across healthcare systems in high-income countries, then middle and then low-income, then I think you can't show a plummeting level of reducing risk, and so that's why it remains a challenge.
My comment would be, it was very courageous of this hospital to admit its, I don't want to say blame, but I mean the error, let's say, and to have changed its conduct, and now it has become again a very high profile, a very established place for treatment of cancer. We don't see that often. I'm a medical doctor, okay, so I can speak freely about physicians and their positions, right? Especially in the low income countries and middle income countries, and sometimes even in the high income countries, because we, let's say, put ourselves in the very high place, right? I mean, we don't make any errors. We don't, and if we have any errors and if we commit any errors, we don't assume that. This is always everybody's.
Yeah. Olympus is a very big place, isn't it, for medicine?
I know, especially for surgeons. But I mean, I understand that we are trying to change the culture of the education of the new medical students, etc. But they go and train in hospitals with the older generation that still feel that they own the place and they don't have any, say in that harming any patients. So they clash that, and they wanted to be part of this group of Olympus kind of gods kind of thing. So they forget what they have learned, or if they are going to press on that. No, but we learn. We have to check that. Do you, Dr. Mr. King of the surgery, do you think that you should check that? He's going to be cut out like that. So I think there is a clash on that. My point is, I know that it's very difficult to measure improvement in this area. It's very difficult. First, because it's very underrepresented, undersaid, under anything, right? But I think we should, I don't know if it is possible or not, right? But I mean, should invest more in the kind of training, in the changing behavior of people, like when Semmelweis started to using, you know, I mean, washing his hands with that product, the death during childbirth plummeted, right? I mean, kind of something like that. Somebody has to come and be, maybe this example of this hospital should be more advertised and saying that nobody got more error occur. We are all human beings, right? I mean, and maybe other hospitals would feel the same way of other health systems to improve that, because I think if we think about it, everybody here has an example of some kind of medical error that they have been through, or they have experienced, or they have heard of. So it's a very big problem, and I feel, I mean, like that we now are talking more about that, which is a good thing.
Just closing on that, because probably that comment could stand on its own, but I do think that that's a big challenge for us, is this change of culture and documenting it. I think there's been a lot of work by scientific institutions on culture change measurement mechanisms, but actually we were on a trip to the Gulf states, in Oman, and were asked sort of, well, how would you examine culture? I think Liam, this would be a paraphrase of it, but came up with sort of three things. He said you should just ask yourself, how many of your doctors care about more than just their current patient rotation? How many of them use data at all on a regular basis, and how many of your senior hospital executives actually walk around the hospital and visit patients and see patients and doctors? And so I think, like, if you could say, is it none, some, or all of them, we would start to realize how far we have to go, and it's a little bit of a one institution by one institution, but that engagement of the clinical leadership has been one of the big things that's been missing from initiatives that have failed. We haven't been gotten buy-in from our senior clinical leadership, and that's a big challenge for us, I think, going forward.